Next question is for patients who are not eligible for frontline IO therapy, what is your decision tree for choosing a VEGF-TKI? And it's typically about 25% of our patients, I think.
So there's a lot of factors that come into play when selecting frontline therapy for any given patient, and in particular when selecting a VEGF inhibitor as opposed to a IO-IO or IO-VEGF combination. I think predominantly the most commonly utilized criteria for selection right now are the IMDC criteria. The data supporting the role of VEGF inhibition in those who have favorable risk disease, and data that was presented by David McDermott from a study looking at atezolizumab and bevacizumab in patients with metastatic RCC, demonstrate that patient population of favorable risk tends to have a signature of sort of angiogenesis. I think other things that come into play are actually sites of metastases, data from particularly for patients who have bone metastases. The frontline study of Cabo's son that was conducted by Tony Sheriri through the Alliance Cooperative Group demonstrated the superiority of cabozantinib over sunitinib. Now that was predominantly done in intermediate and poor risk patients, but the bone predominant patients seem to really derive benefit from the cabozantinib. And so that, could be considered based on site of disease. Additionally, I think patient factors come into play. Do they have contraindications for IO therapy? Are they on steroids to treat some underlying medical condition? Do they have an underlying autoimmune disease? We still don't know sort of the role of the IO therapies from any prospective data in the context of people who have, psoriasis or other immune conditions that may be well managed, where they're not on systemic, steroids or other anti-immune agents. So I think those are largely the predominant factors that come into play. We spoke a little bit during our Twitter chat regarding biomarkers and what's the appropriate biomarker. And there isn't a biomarker at the present time to help with selection of a VEGF inhibitor in the frontline space. I think another thing to consider is likely also histology. That plays into effect. So if you have a papillary tumor, for example, or papillary RCC, maybe you're going to want to use a MET inhibitor, cabozantinib in that individual, or maybe the lack of sarcomatoid differentiation may we know that those patients tend to do better with IO therapy, so that could potentially be informative in patient selection. But I think this is still evolving. We certainly haven't, barring the IMDC, we haven't, specifically conducted prospective studies by carving out based on a biomarker or, selecting out a unique patient population.
So the data for cabozantinib is in intermediate and poor risk, but the FDA approval is across the board. Mm-hmm. In favorable risk patients, are you guys considering this agent in the frontline setting?
Yeah, I think it's something the discussion around favorable risk is the longest discussion that you have with your patient. It's those favorable risk patients who are really going to do well with just about anything that you do for them. And, I think Tian had talked about the various treatment options from, observation all the way to, doublet therapy that you could introduce. And you could potentially make the case that if somebody has, oligometastatic bone metastases, that maybe they may benefit from being on cabozantinib, and it's not enough that you're going to radiate all the spots, but you can put them on the VEGF-TKI over Sutent. So I think you can make a case for a specific patient.